Yes, sir. 3, 2, 1, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we will start with a very sad news about one of our very senior urologists whom we have lost. And he is Dr. Narendra Bhandari. Narendra Bhandari was not only the past president of North Zone Chapter of Urological Society of India, he was from Rajasthan, Jodhpur, and the urological fraternity throughout the country has suffered a great loss. At the end of the class, we will have a 1 minute silence once everybody has joined. So today's class is on evaluation of hematuria, and this would be presented by our resident, Dr. Sarthak Sharma, and would be moderated by our faculty, Dr. Ajayraj Singh Hada. So I would request Dr. Sarthak to kindly share his presentation. Sarthak, go ahead, please.
Thank you, sir. Good morning, everybody. I'm Dr. Sarthak Sharma. I'll be presenting this seminar on evaluation and management of hematuria. Hematuria can be classified according to visibility and timing into a gross hematuria or a microscopic hematuria, with gross hematuria further giving the source timing giving the indication of the source, with initial hematuria giving a source of urethral pathology, terminal hematuria suggesting a bladder trigon, neck or prostate pathology, and a total hematuria giving us an indication that it may be an upper tract or bladder involved. Differential diagnosis important here is pigmenturia has to be differentiated with actual hematuria because it gives a false positive urine dipstick test, and microscopy is indicated, which helps us in differentiating it. Vaginal bleeding in women is again a differential which has to be noted about. You have to obtain a careful menstrual history. A specimen should be taken when a patient is not on menses, and if necessary, a catheterized sample has to be taken. Coming to microscopic hematuria, it is presence of RBC is not visible to the naked eye. It is a sign rather than a symptom, and prevalence in healthy individuals is around 6.5%. It is further quantified by the number of RBCs per high power field and can be categorized as asymptomatic or symptomatic. Now, microhematuria can be a part of a normal process, or it may hide an underlying significant medical comorbidity and malignancy, such as. So, in cases of microhematuria, you should always weigh in the benefit, harm, and cost to go through a total evaluation. Criteria, there are various guidelines available. Noteworthy is AUA guideline, which suggests that in a microscopy, if there are 3 or more RBCs per high power field in a single urine analysis, that then it validates for a thorough evaluation of that patient. Urine dipstick test, if it comes out to be positive, it narrows it down to hemoglobin or some pigmenturias such as myoglobin. So microscopy is always needed. And if it shows a 3 or more RBCs, then you need a thorough evaluation of that patient. When do you require a microscopic evaluation? Urine dipstick alone is insufficient. A positive dipstick, as we already discussed, requires a microscopy, and if it is positive, then full evaluation is required. Now, a microscopy may come out to be false positive if there is a prolonged recumbency, that is, the specimen is collected first thing in the morning or after a vigorous physical sexual activity, and it may come out to be false negative if the urine is very dilute because of RBC lysis. In up to 1/3 to 2/3 of the patient, there will be a demonstrable cause, while malignancy in asymptomatic microscopic hematuria is around 3.5%. And if the degree of hematuria increases with more than 25 RBCs per high power feed, or if there is a gross hematuria, the risk of malignancy will also increase. This table depicts the differential diagnosis, which can be broadly characterized as neoplasia, infection, calculus, taking the major role, and BPH in older age men, and certain medical renal conditions may also present with hematuria. Some risk factors in patients with microscopic hematuria that may suggest malignancy is male gender, age more than 35 years, history of smoking, some occupational exposure to chemicals, some pelvic irradiation history, or chronic UTI history. How do you select the patient of microscopic hematuria for evaluation? AUA says that any patient with asymptomatic microscopic hematuria should undergo a thorough evaluation. Although you should always weigh in the cost, harm, and benefits, and thus many guidelines propagate that in the absence of an obvious benign cause, you need to go ahead with a thorough evaluation, otherwise, it can be avoided. In certain benign conditions, if present, you can avoid thorough examination, like vigorous exercise may give a false positive finding on microscopy. Thus, you need to ask the patient for abstinence from vigorous exercise for certain days and then repeat the urine analysis. If the patient is on anticoagulant, then also you need to go through with a complete evaluation, and you cannot neglect these patients because prevalence of hematuria as well as likelihood of cancer is same to any person not on anticoagulant. If the initial history and physical examination suggests a benign cause, you need to substantiate it, treat it, and repeat the urine analysis. And if there is resolution of hematuria, you can release the patient from your care. Otherwise, you need to go through a complete evaluation. What is the role of screening? Because bladder cancer is one of the most common cancers in the world, but mass screening for bladder cancer is again not indicated because the harms and costs outweigh the potential benefits. This is an algorithm showing how to proceed with a patient presenting to you with asymptomatic microhematuria. You need to go through with a proper history and physical assessment and rule out any benign causes. If benign causes are ruled out, then you can go ahead with renal function testing, cystoscopy, and upper tract imaging, mainly in the form of CT urography. Cystoscopy for bladder, most reliable way to assess is cystoscopy, and this is white light cystoscopy, and it also gives us an opportunity to evaluate the urethra. The AUA guidelines suggest any individual 35 years or more in cases of asymptomatic microhematuria should undergo a cystoscopy. Blue light cystoscopy, it has been US FDA approved, but AUA does not approve it because of rare anaphylactoid shock, hypersensitivity, pain, cystitis, and unnecessary biopsies that will be taken because of it. Upper tract imaging, recommended upper tract imaging is multiphasic CT urogram. It is highly sensitive and specific for renal parenchyma and upper tract lesions. Drawback is it is contraindicated in pregnancy, patient having allergy to the contrast, or renal insufficiency. Also, there is some radiation exposure, which itself is a risk of carcinogenesis. CT urography in case of bladder is not as sensitive as cystoscopy. Only large bladder tumors can be detected. Carcinoma in situ cannot be identified. Therefore, it again emphasizes that cystoscopy cannot be left behind, and it is an important part of comprehensive hematuria workup. MR urogram is only done when there is a contraindication to CT, and if a patient has a contraindication to MRI, such as a cardiac pacemaker, or if there is a significant renal compromise, if there is the administration of gadolinium risk nephrogenic systemic fibrosis, then you can evaluate this patient with NCCT or ultrasound in conjunction with retrograde pyrography. Coming to urine cytology, it is highly sensitive and specific for high-grade urothelial carcinoma, but uh, overall sensitivity is around 15.8 to 54.5% with a specificity reaching to 100%, while sensitivity decreases for low-grade. Urinary biomarkers, there are different available urinary biomarkers such as nuclear matrix protein 22, FISH, immunocytology. NMP22 has a potential advantage that is a point of care test, but there are only two studies in asymptomatic microhematuria, one giving a very high sensitivity, another giving a very low sensitivity, thus it cannot be recommended. FISH for abnormalities of chromosome 3, 717 and 9p21 has also been given, but sensitivity and specificity, sensitivity is moderate for 61%, while specificity reaches 93% for bladder tumors. CERT-NDX assesses several biomarkers, including mutant FGFR3, quantified MMP2, and hypermethylation of TWIST1 and NID2, with a sensitivity 87.9%, but specificity again 56.3% only. What is the current evidence in asymptomatic microhematuria is that biomarkers as well as cytology both cannot be recommended. However, cytology still has a role if the initial workup comes out to be negative and you are still suspecting a malignancy. Now, how do you follow up if there is a negative initial workup? If there is a negative initial workup, you need to follow up with annual urine analysis for 2 years. If the urine analysis confirms resolution of hematuria, you can release the patient from your care. If it is persistent, you need to reevaluate this patient, and the patient should undergo the complete evaluation according to the patient profile. Coming to symptomatic microscopic hematuria, differential diagnosis and causes are same as asymptomatic, but the risk of malignancy here is higher, around 10.5%, which was 3.5% in cases of asymptomatic. Complete workup again can be avoided in the setting you are suspecting a benign disease. You can treat it and revisit with a urine analysis and see if there is a resolution of hematuria or not. AUA guidelines, how it changes is cystoscopy is recommended despite of any age group, and urine cytology has a role here if the patient is having voiding symptoms. Coming to gross hematuria, with increased degree of hematuria, there is increased likelihood that a lesion will be found because 50% usually have a demonstrable cause and 20 to 25% may have an underlying malignancy, most common a bladder or a kidney tumor. Recommended evaluation in gross hematuria is all patients should undergo a cytology, a cystoscopy, and upper tract imaging. But here, first priority is to the stabilization of the patient, and there are no clear-cut guidelines if the initial workup comes out to be negative. Coming to hemorrhagic cystitis, it is intractable hematuria localized to the bladder with diffuse inflammation and bleeding from the mucosa. The causes range from transient conditions that can be easily managed by conservative management or ranging to the life-threatening conditions which require urgent intervention. Problem here is the patients are always elderly and infirm with multiple comorbidities, thus making the plan a little difficult. This table depicts the different causes of hemorrhagic cystitis ranging from infection, trauma, malignancy, some chemical exposure or radiation history. Now coming to certain causes like bacterial infection is a common cause, but it can be easily treated with antibiotics and appropriate supportive treatment. Viral induced hemorrhagic cystitis are more common in children and immunosuppressed patients, with BK virus being the most common and adenovirus 11 and 35 more common in children and renal transplant recipients. Treatment is only supportive, hydration, diuresis, and bladder irrigation suffices. Coming to cyclophosphamide and ifosfamide, hemorrhagic cystitis in patients treated with these are seen in around 2 to 40%, and it is again dose-dependent relationship. Treatment is by MESNA. MESNA has also been suggested in the prophylaxis, but still the patient 10 to 40% time develops hemorrhagic cystitis. Now, cyclophosphamide treatment leads to production of acrolein in liver, which is excreted in kidney, and it causes bladder mucosal sloughing and leads to onset of hematuria within 48 hours of treatment. Coming to patients who have been treated with radiation for pelvic malignancy, the risk of moderate to severe hematuria is in around 5%, and the onset is between 6 months to 10 years of the treatment. If a patient has received both cyclophosphamide as well as pelvic irradiation, then you need to evaluate these patients with bladder cancer before labeling them to be having hemorrhagic cystitis because it itself represents a risk factor. Coming to how the radiation causes vascular endothelium damage, which leads to progressive obliterative enteritis, and the condition is further worsened by the secondary infections that set in, thus compromising the tissue healing in these patients. How do you manage hemorrhagic cystitis? Initial management is usually supportive care with hydration, with or without bladder irrigation and fulguration, also with the use of intravesical agents, commonly used as alum. Alum has, the various studies have showed variable success rates ranging from 45% to 100%, and the durability of the hematuria treatment is limited. Drawbacks is suprapubic discomfort and bladder spasm, and if there is systemic absorption, it will lead to aluminum toxicity, leading to mental status changes. Advantage is overall toxicity of alum is low. It can be instilled without anesthesia and has favorable efficacy and safety profile. Thus, it is indicated as a first-line intravesical therapy. This diagram depicts that we need to make a 1% alum solution, which can be made by mixing 50 grams of alum in 5 liters sterile water, and the irrigation can be done at a rate of 200 to 300 ml per hour. Alum irrigation causes protein precipitation on the urothelial lining, causing vasoconstriction and decreased permeability of the capillaries, thus arresting the bleeding. Coming to prostaglandins, the mechanism of action is unclear. Response rates are moderate, 50 to 60%, and there are difficulties in access, storage, and high cost of these prostaglandins, thus they have limited utility. Intravesical silver nitrate acts as a chemical coagulant, and it can lead to precipitation and upper tract obstruction. Thus, a pre-treatment cystogram is required to rule out any reflux.
Precipitation of what?
So,
Precipitation of what?
silver, it will cause precipitation and the obstruction of the ureteric openings, and this will lead to obstruction of the upper tracts.
Silver nitrate reacts with sodium chloride and forms silver chloride, CdCl2. AgSil2 is very that's it.
Intravesical aluminium, it is a lysine analog and a competitive inhibitor of activators of plasminogen. Thus, it interrupts fibrinolysis. Important here is that the irrigation should continue 24 hours after the hematuria resolution. Symptom resolution is seen in 92%, but there is a risk of thromboembolic events. Here, important is before administration, bladder should be clot free, otherwise, hard clots will form, which are very difficult to eradicate. Now coming to hyperbaric oxygen therapy is indicated in refractory hematuria, especially after radiation therapy or cyclophosphamide. Here 100% oxygen is given at 2 to 3 atmospheres within 90 minutes in 30 to 40 sessions. And response rates are good, 80 to 90%, and they are also maintained up to 2.5 years. But overall 5-year response rate is only 27%. Hyperbaric oxygen therapy, the local tissue oxygen tension increases and tissue oxygen extraction also increases, which helps in wound healing by diminishing edema and promoting neovascularization. Intravesical formalin, it again causes protein precipitation and capillary occlusion. Response is good, around 80 to 90%. But the problem here is it causes significant pain. It can be administered only under anesthesia. Also, the patient needs to be counseled about decreased bladder function because it leads to bladder fibrosis. Installation is 300 ml or up to bladder capacity. It should be under gravity within 15 minutes, and the catheter should be at a light traction to avoid urethral exposure. Also, skin should be protected from exposure. It cannot be indicated as a first-line therapy. Only a second-line therapy is indicated because of its toxicity profile as well as requirement of anesthesia. Internal iliac artery angioembolization, it is indicated in unstable patients with intractable bleeding, usually can be given in debilitated patient, and anterior branch of internal iliac artery bilaterally is usually required to angioembolize to achieve hemostasis. Initial control is good, 90%, but durability is not established. Complication here is if the posterior branch of internal iliac is embolized, it will lead to significant gluteal pain because of occlusion of the superior gluteal artery. Coming to cystectomy with urinary diversion, if all the methods have failed, then this is indicated. Now here, urinary diversion without cystectomy is not recommended because complications have been noted in 80% and rehospitalization rates are also 43%. Now, if a patient is diagnosed with hemorrhagic cystitis, this algorithm shows whatever we have discussed. Initial management is hydration, cystoscopy with fulguration or clot evacuation, then intravesical agents. If hematuria persists, then hyperbaric oxygen therapy. If still it continues, then we have to give formalin at a low concentration of 1%, or we can increase concentration to 4%, and the last resort is a cystectomy with conduit diversion. Hematuria from prostatic origin, it can be because of BPH, prostatitis, or prostate cancer. Coming to BPH, it is the most common cause of gross hematuria in men over 60, and only the expected management with hydration and bladder irrigation suffices in maximum number of cases. Historically, it was an indication for surgery, but now new targeted medical therapies have come up. BPH, there will be high level of VEGF, vascular endothelial growth factor, which results in increased vascularity of the prostate, thus making them prone to hematuria. Coming to treatment, estrogen and anti-androgens have been tried, but only small case reports are available and they are not recommended. Finasteride and dutasteride are 5-alpha reductase inhibitors, which have shown great efficacy in the patients. Even patients on anticoagulant respond to them. Symptom improvement and resolution is seen in 90% of the cases. Coming to surgeries, TURP and similar endoscopic procedures, it is indicated if there is persistent bleeding after conservative management, and also if there are additional indications for BPH. Principle is to remove the transitional zone tissue which is leading to hematuria. Embolization of the prostatic artery, it can be done if TURP again doesn't help. Initial success rates is good, 90%, but reoccurrence is also seen in up to 28% of these patients. Prostatitis is generally secondary to a bacterial infection, and hematuria as a manifestation occurs only in 2.5%. Management is conservative with antibiotics, and recurrence of hematuria is usually uncommon. Coming to prostate cancer, if a prostatic cancer patient presents to you with hematuria, it is usually a high-stage disease, locally advanced tumors to the bladder base and trigonal invasion, and you need to exclude hemorrhagic cystitis from radiation therapy in these patients. Treatment is primarily with a palliative intent because these patients will be elderly and also they will have an advanced disease. But the conservative measures with hydration as well as bladder irrigation usually suffice in these patients. Coming to androgen deprivation therapy, these are indicated in patients who are not candidates for local therapy or the disease has reoccurred after previous local therapy. In these patients, surgery is indicated if there is persistent hematuria and also there are obstructive symptoms. Indicated are cystoscopy with fulguration and or limited or channel TURP is indicated. Coming to selective angioembolization, it is only indicated if even after TURP there is bleeding, but the data to support it is also scant. Last option, if all the methods fail, is again urinary diversion. This algorithm depicts if a patient comes to you with prostate-related gross hematuria, initial management usually suffices, and then you can categorize accordingly into prostate cancer, BPH, or prostatitis. Prostatitis, only antibiotics will suffice. BPH, first line is 5-alpha reductase inhibitor now, and if it fails, then you have to classify accordingly, and clinical comorbidity status should be known. If it is poor, then you can go ahead with fulguration. If it is not, you can go ahead with surgery in the form of various endoscopic procedures. If nothing helps, then angioembolization, and final resort is the diversion. Coming to urethral bleeding known as urethroragia. Urethroragia should be differentiated from hematuria. Uh, it should be differentiated, it should be separate from micturition. A careful history has to be noted. If a woman comes to you with urethral bleeding, you should have a gynecologic, you should help in differentiating if it is a gynecologic cause or not, and pelvic examination is very much required in these patients. Diagnosis is usually by a retrograde urethrogram or a cystoscopy, which has an advantage of direct visualization, and biopsy and fulguration can be done. Differential diagnosis for a urethral bleeding is gender-based into male and female, with main causes being trauma, urethritis, and malignancy. Trauma is the most common cause of urethral bleeding. The signs will be a perineal or penile bruising, and a retrograde urethography is very much essential. Urethritis is again infection or inflammation of the epithelial lining, and urethral discharge will be present on palpation, microscopy, culture, and urethral swabs help in making a diagnosis. Urethral tumors are rare, and they may be a manifesting, hematuria may be a manifesting sign in urethral tumors. Urethral caruncles, again, they are present commonly in postmenopausal women, and they indicate a prolapse of distal urethra because of estrogen deficiency. Urethral diverticulum, classically they present with dysuria, dyspareunia, and dribbling, but intermittent episodes of bleeding may be present, and urethral discharge may be noted on examination. Coming to hematuria from the upper tract hematuria is usually asymptomatic. Patient may present with clot colic and rarely with anemia, and even rarely with a hemodynamic instability. Usually the presentation is total hematuria with worm-like clots. This is a differential diagnosis of upper tract bleeding with glomerular diseases and tubular interstitial diseases, vasculitis, infections, obstructions, calculus, and malignancy being the important causes. Coming to MRDs can be glomerular diseases or tubular interstitial diseases. Glomerular diseases, the usual urine routine finding will be RBC casts, dysmorphic RBCs, and proteinuria. This algorithm depicts how you can categorize and diagnose different glomerular diseases based on the history and their specific investigation. Coming to tubulointerstitial diseases, this can be sickle cell nephropathy or analgesic nephropathy leading to renal papillary necrosis and causing interstitial nephritis. Diagnosis is usually by a percutaneous biopsy. Vascular conditions, it may be ureteroiliac artery fistula, which may be because of pelvic vascular surgery, pelvic irradiation, extensive mobilization of the ureter, or a chronic stenting of the ureter. Management here is angiographic localization with vascular stenting because surgery has very high mortality in these patients. Renal arteriovenous malformations, they can be congenital or acquired. Acquired are usually iatrogenic, and arteriography with selective angioembolization is both diagnostic as well as therapeutic. Renal artery aneurysm is generally asymptomatic. There is a sign patient 90% patients have hypertension. Patient may have flank pain with gross hematuria. Management initially is a blood pressure control, or endovascular approaches can be tried if the patient is stable, or surgical intervention can be tried in unstable patients. Nutcracker syndrome. Nutcracker syndrome represents compression of left renal vein between the aorta and superior mesenteric artery. In Nutcracker syndrome, because of compression of the left renal vein, there will be increased pressure and small volume capillaries will get ruptured in the collecting system, leading to hematuria. Lateralizing essential hematuria. It is macroscopic hematuria, which is cystoscopically localized to one side of the urinary system without a clear identifiable cause, and prior radiographic studies found to be normal. In many cases, there will be no identifiable cause. Here, important is uretropiloscopy. Uretropiloscopy has some critical components. You should have judicious use of guide wires, otherwise, you will cause urethral injury. It should be under low pressure irrigation, and systemic evaluation of the calyces should be done from a superior to inferior approach. Advantage of uretropiloscopy is biopsy samples can be obtained and fulguration of some tumors if needed can be done. This is the take-home message. How do you proceed with a patient presenting to you with hematuria? A patient with microhematuria, history, physical examination is very much important. Rule out benign causes, treat them, and you can revisit with a urine analysis to see if there is resolution of the hematuria. Otherwise, you risk stratify these patients into low risk, intermediate risk, and high risk, and accordingly proceed with the imaging studies, that is cystoscopy or ultrasound in cases of intermediate group. In cases of high risk, you can go ahead with cystoscopy with CT urography and treat according to the causes. Again, the gross hematuria, this is for microhematuria. For gross hematuria, all the patients have to undergo a cytology, cystoscopy, and upper tract imaging irrespectively. Thank you.
Thank you. Thank you, Sarthak. Yes. So I think, yes, hematuria is a very important topic when we consider from point of view of examination also. You can always get a long question, right? And from clinical point of view also, practical point of view, it is said that 20% of our outdoor cases are evaluated for hematuria, right? So it's a very, very high kind of a incidence in terms of OPD patients that we see normally. So when we talk about hematuria, I think you need to understand the hematuria could be symptomatic, asymptomatic, it could be microscopic, it could be gross hematuria, it could be glomerular hematuria, it could be non-glomerular hematuria, it could be kind of patients, even maybe some kind of cause associated with which has been diagnosed. It could be idiopathic. So even almost 50% of microscopic hematuria, they do not have any cause when you evaluate these patients. So this is called idiopathic hematuria, where the evaluation would be totally different, right? And these patients should be properly followed up to find out the cause. When we talk about evaluating a hematuria, yes, the evaluation of microscopic hematuria would be different from gross hematuria. And then in microscopic hematuria, when you told about dipstick test, the AUA says that dipstick test may be false positive, false negative. So you cannot depend totally on dipstick test for diagnosing microscopic hematuria. So the ideal thing is to do a routine microscopic examination to diagnose microscopic hematuria, that is 3 or more than 3 RBCs per power field, high power field. And then in the history, again, it is very important to make a risk stratification also, which is again very important in microscopic hematuria, to have a low grade and intermediate and high grade stratification, which will change the total evaluation, how we evaluate these cases of microscopic hematuria. And then it could be when you talk about gross hematuria, you need to know whether this is coming from upper tract or lower tract, what type of associated symptoms and clots are associated with this hematuria. When we talk about physical examination, again, we need to know a lot of more things, because many of these patients may have associated stones, they may be associated with flank pain, they may have, other factors where you can actually pinpoint the cause for hematuria. So the history is very important, physical examination and lab tests, as he has discussed, urine routine microscopy, and then further depending upon what it suggests, right? Um, when we talk about idiopathic hematuria, it is very important to follow up these patients, whether they have persistent hematuria or not, because many of these could be transient hematuria. As you said, it could be due to exercise induced, it could be due to menstrual menses in females, and it could be due to, and then you have to also rule out sometimes if there is any bleeding diathesis or not, if there are dyscrasias, which could be patients on antiplatelets, etc. Again, very important point made that patients even on antiplatelets or anticoagulants need to be evaluated as those who are not on antiplatelets, because the incidence of malignancy is similar in both the groups. So you do need not just if the patient is on antiplatelet, you have to have the same kind of evaluation. I think that was probably in brief the whole thing. And the only thing is idiopathic hematuria, if sometimes you not only have to rule out transient hematuria, the blood dyscrasias, bleeding diathesis, antiplatelets, drug-induced, plus sometimes you have to go further. Even if the imaging doesn't tell you about any cause, then there's some very rare causes like aneurysms, the AV fistulas in the kidney, and other things which can only be detected by maybe some MR angiography or CT angiography. So these cases require further investigation if on follow-up they have persistent microscopic hematuria. Again, glomerular, non-glomerular, again, it's very important to differentiate. That is, glomerular hematuria would have usually RBC casts, may be associated with proteinuria. And then another thing is acanthocytes. Acanthocytes are usually present in glomerular hematuria, by which you can differentiate between glomerular and non-glomerular. So the treatment would totally different. So thank you. That was in brief the summary on hematuria. If our residents or faculty have anything to say or give any comment or any query, they are most welcome. Any of the residents? Do you have any question? Dr. Nachiket, would you like to talk something?
First is the things that he's told us in the last 25 years. This seminar has not changed. I mean, the way that you told about hemorrhagic cystitis, the management protocols, the intravesical therapies, the advantages, disadvantages. I think that you lost the point where you could have specified more upon benign lateralizing hematuria. That is the end. This is because we know the management of, hematuria due to radiation cystitis and all that, oxygen therapy and all. But if you could have incorporated, now series in which people have studied the various causes of benign lateral hematuria, that would have been, as Sarah said, like bleeding from the prostate, we manage routinely, bleeding from the bladder, we manage routinely, angioembolization. So I think that the gist of the topic was maybe a little offset. And you could have, there are now people who have got case series of 200 cases of benign lateralizing hematuria. We would have maybe focused on that. I think that from the perspective of this seminar, you would have been wiser then. And Bhagito, you covered it well. As I said, it's a very important topic and you can get a long question. And you routinely do. It's one of those recurring questions that you get inside the exam. But I think in the future, maybe we can have another seminar on benign lateralizing hematuria, sir, and what people have found out as the rare causes, as you said, like aneurysms and all, the importance of, again, a ureteropeloscopy, the importance of biopsies, the importance of taking papillary biopsies, the importance of angiographies. I mean, that would have maybe added more, a little bit of glitter to the seminar.
Yes, Nachiket, point well taken, because yes, as I said, the 50% cases of microscopic hematuria could be idiopathic, and these patients need to be properly followed up. And if they have persistent, then you need to do further investigations to find out the exact cause. So there are a lot of things. As he said, there could be rarer causes. Then there is a condition called hematuria dysuria syndrome. There is a nutcracker syndrome, as you said, and so the drug induced, and there were so many causes where you do not exactly find out the exact cause of microscopic hematuria. That has to be dealt with properly. Anybody has anything else to say? We will have, yeah, that's true. We started with that only, and I said in the beginning only that at the end we will have a 1 minute silence. Because till that time everybody would have joined the class. So anyway, anybody has anything, we will just take up the MCQs and then we will have that 1 minute silence, please. Yes, please go ahead. So the MCQs, yes, can you just push it up? Yes. So according to AUA guidelines, microhematuria sufficient to trigger a diagnostic evaluation is defined as a positive chemical test, urine dips showing small, moderate, or large blood. A positive chemical test, urine is showing small, moderate blood, at least 2 or 3 properly collected. A positive chemical test showing large blood on one. Urine microscopy showing 3 or more. Urine microscopy 3 or more on at least 2 or 3 properly collected urine specimen. What do you think? E? E? D. So even one proper collection and a urine routine microscopy showing 3 or more than 3 RBCs is microscopic imaging, right? So dipstick, as I said, can produce false positive and false negative results. So you cannot depend totally on dipstick. So I think that's what they are saying. The presence of 3 or more with malignancy in 2.3 to 5.5% of patients. Chemical tests for hematuria. So this microscopic hematuria has an incidence of around 0.3 to 2-3%, can have malignancy. And if you have gross hematuria, then the incidence is around 10%, 10 to 15% of getting a malignancy. Right. So chemical tests for hematuria detect the peroxidase activities of benzodiazepine and can render false results in the presence of dehydration, myoglobinuria, high doses of vitamin C, improper technique, and other factors. While higher level of microhematuria are known to be associated with higher rates of malignancy on evaluation, setting the threshold higher than 3 RBCs or requiring more than 1 positive urine would lead to an unknown number of missed opportunities for diagnosis. Right. The likelihood of finding a malignancy in a patient with microhematuria is influenced by all of the following except age, gender, anticoagulants, tobacco use, and degree of hematuria. C, use of anticoagulants. So anticoagulants, even if patient is on or not on, will not change the finding of malignancy, as the studies have said. Age definitely more than, so it is said that the female more than 50 or male more than 40, you should evaluate them for the chance of malignancy. Gender, male definitely has higher chance. Tobacco use, again, more than 30 pack years have a very high chance of malignancy. Less than 10 pack years, the chance of malignancy is less. So that is considered as a low risk if it is a less than 10 or non-smoker. And the degree of hematuria definitely is a chance. So according to AUA guidelines, the proper initial assessment of a 50-year-old patient with asymptomatic hematuria includes BP measurement, serum creatinine level, cystoscopy, CT scan, urine cytology, cystoscopy and CT, urine blue light and upper tract imaging, urine cytology, renal blood ultrasound, no evaluation. Pardon? A. So blood pressure measurement is very important, right? BP, because many of these patients of hypertension may have kind of a hematuria. And that's why they are advised to have a low salt diet regimen. Many patients who have hypertension with microscopic hematuria. And serum creatinine level definitely will tell you about the medical cause, cystoscopy, and CT scan. So A, right? Okay. And blue light cystoscopy, as they said, that sometimes it detects the benign causes. So the chances of doing biopsies increases. So blue light cystoscopy is not recommended by AU, right? Yeah. I think that's it. Right. So in the evaluation of patients with microhematuria, cystoscopy may be safely avoided if there are no associated symptoms in a patient of any age, the patient is under 35 years of age and without symptoms or risk factors for malignancy, the patient is taking aspirin or warfarin, the cytology is negative, the patient has a history of UTI and hematuria is still present after the treatment. B, so the patient is under 35 years of age, asymptomatic, and no risk factor for malignancy. So that there you can safely avoid the evaluation, but again, they need to be followed up, right? They may have, if they have persistent hematuria, then definitely they have to be evaluated. I think that's it. UTI, if the UTI is associated with hematuria, you should always follow up these patients and ensure that there is no hematuria microscopic after the UTI has subsided. So that is very important. If it persists, then you have to evaluate. Patients presenting with gross hematuria in the absence of recent trauma or concurrent infection who are on anticoagulation medication should be evaluated with urine analysis, cytology, cystoscopy, CT with cystoscopy only if symptomatic, no evaluation, assessment of anticoagulation status, and evaluation only if supratherapeutic, urine cytology, cystoscopy, and CT urogram. E. So the patient has gross hematuria, no need of urine analysis. Yet always is saying that the patient has blood in the urine. So urine cytology is important, cystoscopy and CT scan, all these. I think it's okay. Fine. So given the increased frequency with clinical significant findings are associated with gross hematuria, the recommended evaluation in this setting is relatively uniform. Patients presenting with gross hematuria in absence of antecedent trauma or culture documented UTI should be evaluated with cytology, cystoscopy, and upper tract imaging. Importantly, patients who develop hematuria who are on anticoagulation medication should undergo a complete evaluation in the same manner as patients not taking medications, as the prevalence of hematuria, as this has been discussed, right? Use of intravesical alum for hemorrhagic cystitis should be avoided in patients with history of malignancy, history of retrocellular instability, active gross hematuria, renal insufficiency, VOR. Renal insufficiency, right? So we all know that we have been using alum quite often in our patients operated with TURP, but patients who have CKD, you have to be very careful because alum toxicity can increase renal toxicity. The molecular pathophysiology linking BPH and hematuria is exemplified by the identification of which of the following in the prostate tissue for men with BPH. Decreased microvessel density, androgen-independent angiogenesis, elevated VEGF expression, reduced cell proliferation, diminished blood flow. Say elevated VEGF expression. So we have discussed already. There's a elevated VEGF expression, the increased microvessel density, and I think all these factors would increase prostatitis, increased blood flow, congested prostate. All these have chances of more hematuria. And then definitely we have discussed about vesicle piles and all that. Patients who are present with chronic retention, etc., they develop vesicle piles, and once you catheterize them, then they could have hematuria, right? A 65-year-old man with a history of BPH has recurrent gross hematuria. The patient is clinically stable with no transfusion requirement, no clots in the urine, and no difficulty with bladder emptying. A hematuria evaluation with CT urogram, cystoscopy, and urine cytology is otherwise unremarkable. The best next step in management is 5-alpha reductase inhibitor, alpha blocker therapy, prostatic artery embolization, channel TURP, trial of antibiotic therapy. A. So a patient with a history of BPH with recurrent gross hematuria, with no transfusion requirement, no clots in urine.
This is a dubious question, I guess.
This is a little dubious.
Itself is an indication of
Right. Yeah. So only thing is about the clots that they are saying. The absence of clots would probably go more in favor of glomerular hematuria rather than non-glomerular hematuria or the surgical cause. So that is important when you differentiate glomerular, non-glomerular hematuria. Though even with glomerular hematuria, there may be clots, but usually they do not. Anyway, yes. So treatment with 5-alpha reductase inhibitors has been associated with decreased VEGF expression, prostate microvessel density, and prostatic blood flow. Clinically, multiple studies have demonstrated the effect of finasteride on BPH-related hematuria with symptom improvement or resolution consistently noted in about 90% of patients. I think if they respond to finasteride or this, then it's okay. Otherwise, if they continue to have hematuria, definitely we need to evaluate.
But sir, the standard teaching of indications of TURP have been either stone formation, severe symptoms, recurrent hematuria, upper tract changes, and recurrent UTI.
Yes. Yeah.
So if he's having recurrent hematuria, then he is a candidate of getting a TURP. He himself said that only the transitional zone needs to be removed during a hematuria in prostate. This is what it was in a seminar. Even I was thinking, why not remove it in the capsule? But he specified that it has to be just the transitional zone.
Okay, recurrent hematuria, whether this is an absolute indication for TRP, I still have doubts. Because recurrent UTI, stone formation, definitely obstructive uropathy, everything, they are absolute indications, definitely. But recurrent hematuria, if they are responding to 5-alpha reductase inhibitors, why should you do TRP in every case? If they are responding to 5-alpha, I think that may be debatable. A 35-year-old man presents with complaint of penile pain and immediate detumescence during intercourse. Physical examination notes blood at the urethral meatus. The next step should be immediate operative exploration, CT scan of pelvis, retrograde urethroplasty, obtain serum coagulation parameters, conservative management, serial examinations. So what do you suspect in this patient? Fracture pelvis, right? So again, let me tell you, there are a lot of patients, usually the typical kind of a clinical feature of a fracture penis is a swollen penis with bruises and discoloration of the whole penile skin and blood entering into the different tissue spaces. But there are cases where you do not find any kind of swelling of the penis and you just have bleeding per urethroregia, right? So where the whole thing, the whole blood which after the fracture goes into the urethra because of associated urethral trauma, and nothing comes out into the tissue spaces. So you won't find any kind of swelling of the penis, only there is presentation with hematuria. So this could be a kind of presentation. So what is your answer? C, retrograde urethroplasty to rule out urethral trauma in case of fractured penis. Yes. So many times they may not exactly give this extravasation, say on retrograde urethroplasty. And there you need to do a urethroskopy to rule out the urethral trauma. So many times the retrograde urethroplasty may not be conclusive, right? So consistent with acute penile fracture, blood at the meatus raises suspicion for concomitant urethral injury that requires investigation. Conservative management poses the risk of untreated urethral and corporal injury that can result in use. So very important. It can, many of these patients who have associated urethral trauma in fracture penis develop urethral stricture disease later, right? Erectile dysfunction is fine. Everybody knows. But urethral stricture disease, so you need to take a proper history in these patients. Many of these patients would not give the history unless you actually ask them properly whether there was some kind of trauma or this snapping sound while during the intercourse at any time, right? And some kind of maybe blood at the meatus after that. So if you take a proper history in these patients who have poor flow afterwards, you will find that this urethral trauma has resulted in stricture disease. Right.
Hey, this is one question that we frequently don't ask inside the history of urethral stricture.
Yeah.
And we consider it idiopathic.
Yeah, that's very true. That's what in one of the yes, very important. Because in one of the classes also I said there was one of the I think CMEs where the idiopathic hematuria in the last conference only we were discussing this. Dr. Ganesh Gopal Krishnan had this workshop where I had suggested that there could be a history of such kind of a urethral trauma in with fractured penis. Yes. So a 55-year-old woman presents with intermittent gross hematuria 2 weeks after undergoing a right partial nephrectomy for a 4 centimeter solid enhancing renal mass. She is febrile with stable vital signs. She is able to void to completion and her urine is red without clots. Her creatinine is 1.1. The next step should be renal angiography. Right. So many of these patients after partial nephrectomy may develop AV fistula or aneurysm. You must know this, right? While taking the sutures, when you take a kind of a deep sutures where you can take sutures into the vessels, major vessels, sometimes the segmental vessels, and they may form AV fistula and aneurysm. That is the cause for hematuria post-operatively after partial nephrectomy. We had cases like this, yes. So renal angiography should be done to rule out this. So renal angiogram may be both diagnostic and therapeutic in this scenario with ability to coil or embolize the abnormal vascular communication. Observation and bladder irrigation do not address the underlying positive factor, while non-contrast CT imaging fails to delineate the vascular anatomy. The surgical exploration has a high likelihood of renal loss and is reserved for cases refractory to angiographic modalities. I think that's it. Thank you very much. And again, once again, if anybody has any query or any comment to make, you are most welcome. Those who have joined us today in our class, they may ask if none has any. Again, I would, as I started the class with, that we have lost a very, very important and very senior urologist of our fraternity is Dr. Narendra Bhandari. So Dr. Narendra Bhandari, he was the past president of the North Zone chapter of Urological Society of India. He was professor and head of the department at Jodhpur Medical College. He was residing in Jodhpur. He had some issues in last few years and he was suffering from some problems. But the news came as shocking because he often was very in the groups he used to send messages also, and we never expected him to pass away so suddenly. So we offer our condolences from the Department of Urology at Savai Man Singh Medical College and the urological fraternity, not only from Rajasthan, North Zone, but the whole country has very irreparable loss, has suffered a very irreparable loss. So we will have a 1 minute silence. I would request all of you to please stand up. Thank you. Thank you, everybody.
Do you remember anything about Dr. Bhandari? Sir, I remember one thing.
Yeah, please come. So
when
I joined as faculty, I was posted in Jodhpur Medical College. I was there for almost 1 year, and under Dr. Narendra Bhandari only. And I remember he was administrator and organizer par excellence. He had organized one of the very earliest UCCons in Rajasthan, which was a superb kind of a conference and was very successful conference. And then as soon as I had joined the faculty, we had two conferences organized. So we did one of the National Conference of Andrology, that is Andro India. That was the year 1997, right? Andro India, where we invited many international faculty. There were around 7-8 international faculty coming, including Dr. Rupin Shah and everybody who had come for this andrology conference. Then we organized a workshop with Dr. Asopa. Dr. Asopa had come for the hypospadias workshop. So within a short span of 9 to 10 months of my joining there in the department, we had these major conferences organized. So he was, and this was all credit goes to Dr. Narendra Bhandari, who actually inspired me and helped me and was the main person behind these two meetings. Though I was the organizing secretary, but I think without him, it was not possible. So we once again really very saddened by the fact that he has left away so suddenly. Thank you. Go ahead.
So I didn't work with Dr. Narendra Bhandari, but as you had joined for 1 year, I had also joined Jodhpur as a faculty for 1 year. I think this used to be the usual trend that when you get through RPSC, then you never used to get Jaipur. You used to go to Jodhpur or some periphery, then you had to work your way to Jaipur. So I remember when I joined, then I knew that sir had been previously for 1 year. And as a note to his legacy of a tough administrator, there was a story doing the rounds that you should not ask for any leaves. I think that it'll validate us when we refuse leaves to you people. And sir had fractured his leg. And I think that you were in a cast or something, sir. It was an ankle fracture. And
yeah. So only thing is, I had really, when this conference was getting organized, the International Andrology Conference, there was something which happened. Please. So the whole conference that I did, the hypospadias workshop, and then this I did in with crutches, right? So I used to attend everything, the whole conference.
That was a mellow way of saying it.
Yes.
So when he had his fracture and he was in a cast, and I think Varsha ma'am was also there. So yeah, so he was alone over there, and just then he had his injury and he was resting at home. So in the evening, Dr. Bhandari came and visited him, and sir thought that he's come to give a visit to me. The visit was there, but then at the end of the visit, he was politely asked to join the department the next day. So there he was working with crutches, and he used to go to the department on one leg. So that's why if you think that we don't give leaves to you, then you better remember this story. So that in even with a fractured leg and with crutches, on the second day you had to work as a lecturer, do the OT and do everything. So before asking for any leaves, think of what has happened to us inside the past, and then say things.
So it depends upon all how you take it. Definitely, I was quite as a very young faculty, I was very passionate about everything. And I think after 2 days only, I had joined the department, and it discontinued for 3 months because it was a comminuted ankle fracture. So there were more than 20-30 pieces of the ankle bone. So I continued on crutches for 3 months. Anyway, so this tells you how strict an administrator he was, Dr. Narendra Bhandari. And I really salute him for his administrative capabilities and his organizing capability. So once again, we offer our condolences to Dr. Narendra Bhandari. And thank you, everybody, for joining the class. Have a good day.